Hi, my name is Ajrin Nawaz, and I'll be presenting on diabetic retinopathy and how to bring about equitable care. Let's dive in. I'm a rising senior at Rockridge High School with a strong interest in public health and research, especially related to diabetes and its complications. I conducted research with Dr. Muhammad Shakir at Walter Reed National Military Medical Center, publishing a research paper on diabetes, with interest in diabetic retinopathy. I also did an internship and shadowing in the ophthalmology department under Dr. Jonathan Buttram, observing surgeries and diagnostics. I was able to see a patient with diabetic retinopathy and how it impacted his life. I serve on the Youth Advisory Council for the Alzheimer's Association. I'm a companion intern with Loudon Caregivers, supporting elderly and disabled adults, and volunteer with Arms Wide Open to raise childhood cancer awareness. I'm currently training as an EMT, and at school, I'm the founder and president of the Podcast Club, serve as the communications director for the Pre-Professional Health Honor Society, and promote mental health through sources of strength. I also have more than 400 verified volunteer hours. What is diabetic retinopathy? Diabetic retinopathy, also known as DR, is when chronically high blood pressure and sugar damages blood vessels in the back of the eye, known as the retina, which is responsible for converting light into neural signals. Tiny bulges called microaneurysms form. Fluid and blood leak out, causing swelling, lipid deposits, and ultimately the death of photoreceptors and nerve fibers, as you can see in the fundus photo on the right. Today, an estimated 103 million people worldwide already live with DR, and without better prevention, that figure will climb to 161 million by 2045. That's why timely screening and treatment are essential. In its early stages, DR is silent. By the time symptoms appear, retinal damage can be irreversible. In fact, up to 50% of people with DR are undiagnosed until vision loss occurs. Even though the need for screening is big, fewer than 1 in 4 people worldwide receive the recommended yearly screening. The result? Preventable blindness that disproportionately affects working age adults, deepening cycles of poverty. Why does screening fall short? First, there simply aren't enough ophthalmologists. About 9 per million people in many low and middle income countries, versus 79 per million in high income countries. Clinic visits mean long travel, lost wages, and out-of-pocket fees that families can't spare, in addition to invasive testing involving dilation. The devices have been designed for specialists, and not necessarily for nurses and technicians, which makes them more difficult to use. And together, these barriers keep sight-saving exams out of reach. Teleophthalmology flips that model. The non-mydriatic handheld camera captures high-resolution fundus photos in primary care clinics or even community halls. Images upload securely to a cloud server where graders or AI algorithms flag sight-threatening diseases. This solution is relatively cheaper, accessible, and non-invasive. Importantly, technicians can operate the cameras, freeing ophthalmologists to focus on treatment. To quantify impact, I conducted a Prisma-guided meta-analysis of 50 peer-reviewed studies from 15 countries between 2015 and 2025, using PubMed and Google Scholar. Using a random effects model, the pooled accuracy reached 89% sensitivity, which measures how well it detects people with DR, and 91% specificity. And this is how well the test avoids false positives. Cost utility data were striking. In rural India, each disability-adjusted life year cost was $390, considered very affordable by the World Health Organization. In Canada's Indigenous communities, the cost was 281 Canadian dollars per new DR case detected. Perhaps most impressive was the screening uptake doubled when services were offered locally, showing that convenience matters just as much as technology. Let's zoom in. In Zambia, a pilot deep learning algorithm achieved an AUC of 0.97 with minimal training data, showing that robust AI isn't just for big data nations. India now screens thousands daily through state-run tele-DR vans, integrating AI triage to handle volume. Singapore's SIDR program cut specialist workload by 50% while maintaining 90/90 accuracy, a template that low and middle income countries can adapt as connectivity improves. Singapore estimates 29 million Singaporean dollars saved per screening cohort that avoided vision loss and productivity gains. When coupled with timely laser or anti-VEGF therapy, telescreening can prevent up to 95% of diabetes-related blindness. And overall, portable screening lets health systems deploy technicians, empower AI, and preserve vision before costly surgery is needed. The burden is huge. 103 million people already have been affected, and it's rising. Traditional clinic-based exams miss those who need it the most in low-resource settings. The evidence, including my meta-analysis, demonstrates that handheld cameras plus cloud grading delivers high accuracy and saves health systems money. To increase screening efforts and stop diabetic retinopathy, we can scale community-level screening through using portable AI-enabled telescreening. And if we commit to these steps, we can mitigate preventable blindness, and together we can see a brighter future. These are my references, and I would like to thank my mentors at Walter Reed, my research collaborators, and the GHLC organizers for giving me this opportunity. Thank you. I'm happy to connect. Here's my email. I look forward to your questions.